Here a case of intumescent cataract in patient with Fuchs Heterochromic iridocyclitis. This is a 45-year female patient who presented yesterday complaining from drop of vision in her left eye. Her slit lamp examination revealed intumescent cataract with diffuse stellate KPs on the back of the cornea. The iris was normal and the right eye was completely normal. I started the surgery for this patient with clear corneal incision 2.4 millimeter, then using the Trepan Blue with OVD to form the antechamber. Then I prefer to use the double rhexis technique in this patient to avoid any peripheral extension and Argentinian flag sign. After doing a small rhexis, I use the cannula to aspirate the milky fluid to depressurize the lens. Then using the micro scissor to cut the anterior capsule, small snip, then continue the second rhexis, which is about 5 or 5.5 millimeter. Fuchs heterochromic iridocyclitis usually affecting the adult people in the third and the fourth decade of the life, and this condition is usually unilateral and can be bilateral in 10% of cases. The landmark for this condition is the diffuse stellate KBs, and sometimes you can find in the angle abnormal blood vessels, which can lead to bleeding into the anterior chamber after doing the side ports, as we can see later on this case. Now doing the gentle hydrodissection, as this soft as the cortex is emulsified, then injecting the viscoelastic to lift up the cortex and epinucleus from the nucleus, doing the two side ports. Then continue regular phacoemulsification using the horizontal chop technique. And patients with Fuchs heterochromic cyclitis are at risk for developing glaucoma, open angle glaucoma, as the incidence of the anterior peripheral anterior synechia and posterior synechia in this condition is very rare, and the patient usually presents with drop of vision because of the cataract, which can develop into third of cases, and sometimes the patient presents with a floater, as the condition is low grade uveitis and anterior vitritis. Here we can see the bleeding from the angle away from the side port. This is the Amsler sign. You can see in this white arrow. Here is the bleeding, and this bleeding usually does not affect the prognosis of the surgery, as the cataract removing the cataract in those patients has an excellent prognosis comparing with the normal conditions. Now removing the cortex using the irrigation aspiration by manual IA. And those patients, it's very important to monitor the intraocular pressure after removing the cataract, and during a regular follow-up, as I said before, those patients may develop glaucoma, open angle glaucoma. Now after removing the cortex, I am implanting the IOL. It's hydroimplantation using the irrigation in the antechamber to keep it formed together with the bag, then implanted a single piece hydrophobic IOL using the IA probes to centralize the IOL in the bag. Now the lens in the bag, and you can see here the key piece on the back of the cornea through the red reflex. It's very clear. Now injecting a mycol to constrict the pupil and doing the hydration of the incisions of the cornea. It's very important to keep the pressure of the eye normal, and I prefer in those cases to inject air bubble by the end of the surgery, which works as a tamponade to prevent more bleeding from the abnormal blood vessels in the angle into the anterior chamber. Here is the air bubble, and the pressure of the eye should be normal, not too much high. Now testing the leak, and the surgery went very well, and thank you for watching.